Ladies and gentlemen, it is my pleasure to present on behalf of my group about genetic aortic disease and when endovascular repair is the best option. It's my great pleasure to be part of the Thoracic Aortic Symposium, and I'm very sorry that I'm not able to be with you in Australia, and I hope that we will see each other soon at a different place. This, of course, is a very controversial topic, and I am happy to discuss this presentation after my talk. These are my disclosures. Aortic root aneurysm and aortic dissection are two of the most catastrophic events that can happen to patients with genetic aortic disease, and they are typical for this disease. And the dangers of these have led to an early prophylactic surgical treatment with a usually valve preserving root repair. And in this very large multicenter study where George Matlanis has been a part of, it has been shown that this repair can be done in young patients with a very low mortality rate, around 1%. This study and others have led to the general understanding and conclusion that genetic aortic syndrome patients are generally fit and young. And it has added to a dogma which is present in this group of patients that these patients very well tolerate open surgical repair in general. And the history of stent graft repair, which has led to an maybe over excessive use in the beginning, has also triggered a dogma saying that genetic aortic syndrome patients do not tolerate stent grafts well in native aortic landing zones. And therefore, it was assumed that endovascular therapy cannot offer good long-term results in this patient group. In my personal view and the experience in our center here, the reality in genetic aortic syndrome patients with aortic disease which are presenting to us is that these patients frequently are old, they have multiple previous operations and are cardiopulmonarily compromised. They do not tolerate open thoracoabdominal repair well, and therefore they are frequently turned down for open repair. In our experience, genetic aortic syndrome patients tolerate stent grafts well in native landing zones under certain circumstances and when devices are chosen correctly. So in our view, endovascular therapy can offer good long-term results in genetic aortic syndrome patients. And I'd like to illustrate that in the upcoming slides. But first, about open thoracoabdominal repair. Of course, this is a beautiful procedure which we as open aortic surgeons love. Nevertheless, this field has been lost mostly to endovascular repair in the majority of patients. And if we look at the results of this type of repair, even in standard patients, as in this large multi-center systematic review of almost 1,000 patients, you can see that the mortality, even when applied to young patients without genetic syndromes, the mortality is significant with 11%. Here's another center from one of the most experienced European group from two neighboring hospitals from Maastricht and Aachen, who has looked at the result of thoracoabdominal repair after arch repair. And although patients again are very young with 45 years of age, you can see that the in-hospital mortality with 90% is at a level which is today very hard to convince a patient to undergo if the endovascular so-called minimal invasive technique offers so much lower mortality. So redo surgery, which it is in most cases when we see patients with genetic aortic syndromes, is not very frequently performed, and generally open repair is preferred, but the multiple previous operations, the biologically often older patients with difficulties in the access due to their chests, and also the preference of the patients usually leads to prevents the execution of open repair in these patients. And that is a natural and normal thing. The big question is there room for endovascular arch repair and also thoracoabdominal repair in genetic aortic syndrome patients? Let's have a look at the guidelines. The European Society guidelines, they clearly state that open surgical repair for thoracoabdominal aortic disease is the first option, and that is very clear. Looking at the somewhat earlier thoracic guidelines, the recommendations are a bit more open, despite stating that genetic syndrome patients can be repaired at a lower threshold of the diameter. They also say that patients with these diseases may offer endovascular repair in redo situations and in emergencies when it is seen as a bridging procedure. So this is a small opening for endovascular repair. When we look at the reality, patients are not infrequently treated endovascularly, but to understand why this is done, it's not because of ignorance of the guidelines, but because in many cases the diagnosis of these patients, of the underlying condition of these patients is unknown. Frequently, patients are not fit for open repair, or endovascular repair is used as a bridging between two replaced aortic segments. And this is where endovascular repair today is strongest, in my opinion, in this specific patient group. In a review from a few years back, Dietmar Böckler has summarized the results of endovascular repair in genetically triggered disease patients. And the very high conversion and mortality rate of more than 50% has led many of my colleagues to consider endo absolutely no option in these patients. In my opinion, this is throwing the baby out with the bath, as all these studies have been very outdated, using very old devices, and in a way that we would not do today. Other groups looked at endovascular repair, as this one in Marfan patients. And here you can see that a group of 18 patients had a considerable mortality of 11%, not so far from what open repair reports. Another group from France, from Stéphane Haulon, has reported their experience with 17 patients with genetic syndromes with a 100% success rate and with no early mortality and only one reintervention and one death on follow-up. In Hamburg, we have analyzed our patients a few years back, and up to 2018, we had treated about 30 patients with genetic diseases. And you can see that this is a mixture of different entities and also different repairs. So it's really hard to compare, and as also the repairs were very different. As you see here, the proximal landing was in many cases in graft material, but also sometimes in native segments. Distal landing, again, was frequently in graft material, but in more cases in the native segment. The ICU stay of these patients was not very long, but we had a considerable mortality, and this mainly due to the fact that many of these patients were urgent and emergent repairs. But there are many examples of endovascular repair with very good long-term results as well. Just as an example, here's a patient who received a T-bar and a Phi-bar in a Marfan syndrome 5 years ago, landing in a native zone 2. Here's a patient with an 8-year follow-up in native zone 2 in Ehlers-Danlos syndrome. A typical patient, which I remember well, is this less than 40-year-old patient who had a large number of previous open repairs, as you can imagine, and he was at that time blind and in a wheelchair. And although young, he absolutely refused to undergo open repair while his thoracoabdominal aneurysm was increasing in diameter. And he had one of his segmental arteries reimplanted, as the arrow indicates here. So in this patient, we decided for an endovascular repair with an endograft with 7 branches, as the patient also had multiple renal arteries. And one of the branches was used to revascularize the reattached segmental artery at TH11, as you see here, showing that also endovascular repair may be able to reattach those arteries, and the patient did not have a deterioration of his motor function post-operatively. We have also reported this very small number of 2 patients of Ehlers-Danlos syndrome undergoing complex thoracoabdominal repair. And these procedures, which can be disastrous in open surgery, have been did quite well. And as you see, these patients, we had a previous open replacement of the proximal landing zone as well as of the distal landing zone, just leaving the stent graft material in contact to the native renovisceral vessels. Another option when considering treatment in genetic patients is a hybrid repair, which is a new upcoming device from Terumo Aortic with the name ThoracoFlow. This is a hybrid device and acts similar to a reversed frozen elephant trunk. And as you can imagine, the case that you see here, post-FET repair, is quite a challenge when doing in a fully open fashion. So this patient received, beside the first colembolization of segmental arteries to reduce the risk of spinal cord ischemia and back bleeding, a ThoracoFlow device that you see here after a stent graft extension to the celiac artery with attachment of all the renovisceral arteries with an open anastomosis, and a final result that is displayed here. I'd like to show you one interesting case which illustrates a little bit the differences between endovascular and open surgical repair, which are somewhat typical for our patients. Here's a patient where a CD landed in my mailbox in 2019, and as you can see, he had quite an extensive and large aneurysmatic dilatation of his chronic dissection. He was 30 years old and widely healthy, and did not have any significant previous operations and no stenotomy before. As you can see, the root was a 5 centimeter, so today that would have been an indication for root repair, but the thoracoabdominal aneurysm was clearly larger with almost 8 centimeter diameter, and he had a pectus incurnatus, making open surgery difficult, and the fixature interne making the imaging quite challenging. So when we discuss this patient in our aortic board, typically the result was that the patient should receive a frozen elephant trunk as a first step in order to create a landing zone and repair the root, and then most likely undergo an open Crawford repair, or alternatively a Y graft and a B bar. The procedure was performed about a month later, the frozen elephant trunk with a valve-preserving root repair and the Thoraflex hybrid procedure. The operating time was 11 hours, but the patient post-operatively developed a acute respiratory distress syndrome. He was put on ECMO 2 days after the procedure. He received tracheostomy and multiple re-operations due to healing problems and bleeding. In an aortic board, another month later, when the patient still was on ICU, he had recovered to an extent that further steps appeared meaningful. And the conclusion at that time point was that the patient should receive another CTA and a renewed discussion. The new CTA, which is now about 2 months after presentation, shows a very nice result of the FET, but of course the still perfused, extremely large thoracic and thoracoabdominal false lumen aneurysm, which was about at a diameter of 8 centimeters. So we stuck to our original plan, and the patient received an aorta-iliac Y graft with a hemoshield prosthesis, again with a long operating time of 6 hours, but he tolerated that initially well. But the day after the procedure, he had to go back for relaparotomy because of bleeding and hemodynamic collapse, with some other additional complications. Required another depacking procedure, back therapy, etc. So when another few weeks had gone by, the patient then was due to an extension with a T-bar, and at that time point, because of the complicated course of the treatment, it was decided that he should undergo endovascular repair for his thoracoabdominal segment. And this was done a few days later. He received a off-the-shelf T-branch device, and all the false and true lumen originating arteries were attached, and the operating time was 3.5 hours. He was extubated on the table with a OK neurology, and he was in the peripheral ward 5 days later after 51 days on ICU, and discharged a little bit later. Here you see the images of this genetic patient receiving a branched endovascular repair, which I am convinced was the right decision for this patient. So, just to summarize our treatment strategy for genetic patients in Hamburg, we consider endovascular treatment in all genetic aortic syndrome patients, and we prefer endovascular repair when either can be done by bridging replaced aortic segments and in older and comorbid patients. In our mind, zone 2, as we have experienced many times, is a relatively safe landing zone in genetic aortic syndrome patients, especially in patients with Marfan syndrome, not in Loeys-Dietz syndrome patients. But non-bare stent T-bar devices should be used. In our mind, low and precise oversizing and landing in straight aortic segments is paramount when achieving good results in this patient group. As you can see, also more complex artery repairs can be done with good results in genetic patients. Of our experience up to 2017 with 50 cases, 5 patients had genetic aortic syndromes. None of those had a mortality or a stroke, and 1 had a stroke. The principles of repair are different in genetic patients today. So we frequently replace peripheral vessels where we want to land in with our stent grafts by dacron. Let me to conclude. In my mind, there is no place for dogmas in aortic surgery, and patients with genetic aortic syndromes expect to be offered modern, contemporary, minimally invasive techniques when justifiable. Treatment of these patients should be centralized to aortic centers that can offer all treatment options. Thank you very much for your attention, and it's my pleasure to answer your questions.